Dr. Bezerra, ISR is a hot topic right now, and it's something that we encounter in the cath lab not infrequently. Would you agree, about 10% of interventions? So when it comes to ISR, how does OCT fit in, and where do you find it to be useful when you gather that information with OCT?
Yeah, I think, Megan, the simple fact that this is a stent failure, I think interventionists really need to be humble and accept that you already start with a failure and you really need to go the extra mile and make sure that you're optimizing that result. So I think imaging is imperative on any sort of stent failure, either ISR or stent thrombose. Specific for ISR, I think the algorithm is asking the first question: is this a mechanical failure or is this a biological failure? That you can translate: is this stent originally underexpanded? That would be the mechanical failure, or more rare stent fracture kind of situation. But let's stick with the most common situation. Is underexpanded stent, or is this mainly driven by a lot of tissue proliferation? So that's the first question that you're gonna need to answer.
So when you're using OCT to determine whether you have a biological failure or a mechanical failure, how do you assess that OCT image? Do you do measurements? Are you looking for things visually? Can you break that down for me?
Sure. So every time, both de novo or ISR, when we talk about expansion, you need to quantify things, right? So how you quantify underexpanded stent, or how you quantify the expansion of a prior stent? The software, as you know, can detect the struts, but is not displaying to you directly an actual stent diameter or stent area. So you need to select the cross section in which visually you believe the stent, the prior stent, is the smallest, and quickly do a diameter measurement on that cross section. Then you're going to compare the diameter with your reference vessels, right? So as a simple example, you have a reference vessel that is 3.0, your prior stent is 2.5, that's an underexpanded stent.
Now, when you have an ISR case as standard, are you always performing that measurement, or are there instances where you look at it and you say, no, this is definitely a biological failure, I don't need to move forward with making measurements?
I think that's a fair statement. I think qualitatively you can see that you have a very large stent. I would still recommend, it really doesn't take much to draw a diameter, and your reference, you have it for free, your lumen reference. So I think it's important to systematically do that measurement. So you say, okay, prior stent is properly expanded, I lost lumen just by tissue proliferation, and we're going to call this a biological failure, right? And then the next question is what kind of tissue you have inside. So there is three main groups, like a de novo lesion. You can have intrastent, mainly fibrotic component, or you can have a lot of calcification, or you can have a lot of lipid.
So when you're in this instance where you have a stent and the mechanism of failure is biological, and you're assessing the tissue, you have 3 different types of tissue that may be present depending on the case. What is then the algorithm for treatment for that patient once you've assessed the tissue with OCT?
Yeah, it's fascinating because this it's tied to what kind of tools are available, and we are having more and more devices that we can consider. But let's start with the majority of ISR. The majority of ISR is going to be predominantly fibrotic component, and with a prior stent that is well expanded, right? So this is the majority of your ISRs. On this scenario, another layer of stent, and recently proved on a iLumen 4 sub-study, another, in the case was a Xience stent. The second layer of Xience has the same TLR rate as a de novo lesion.
Okay.
So very good results, no additional therapy needed, and similar target vessel failure than de novo lesions.
Dr. Bezerra, what new data or information is out there around ISR and the number of stents that you could or should not put into a patient? And does any of that data involve OCT imaging at all?
Yeah, a recent data that just came out, part of a pre-specified endpoint on iLumen 4, is a direct comparison of a single layer stent being treated with another layer of Xience versus the novo lesion, and it reached the non-inferiority endpoint. In other words, it performed equally well as if it was a de novo lesion.
That's great. So, it sounds like based on that data, then you can be confident in a situation when you do need to place a second layer of stent, utilizing OCT to figure out what your treatment algorithm is, and if a second stent's warranted, the outcomes are going to be
That's
equal.
correct. I mean, because all the scrutiny and the discipline of imaging was present there, right? So this was formally part of the iLumen 4 study and was OCT guided.
Right. If we're in a scenario where it's not a fibrotic, characteristic of the tissue inside the stent, maybe it's calcified or it's lipid, does the approach change there? Are there different algorithms or thought processes around maybe how you would prep that for potentially a second layer of stent?
Let's start with the calcium. So the calcium, I think we need to think similarly to de novo lesions, that if you reach thresholds of calcium that you believe calcium fracture is going to be difficult to obtain, same algorithm that we have for the de novo lesion should be truly considered, including high pressure balloons, probably a second round of OCT to make sure that you achieve calcium fractures. So I would treat calcium similarly to a de novo lesion, if not even with a higher degree of intensity. One thing to keep in mind is that if it's a very old stent, you might have a situation that you have calcium in the luminal side, and you also have calcium behind the stent. So this is a very challenging situation for you to deal with. Again, you want a maximal expansion of the original segment, because you are adding material there. Right. You are making a lumen smaller and smaller, and you need to anticipate that this patient might restenosis again.
So what would you do in the instance then when your OCT is showing that inside the stent it's a lipid-rich neoatherosclerotic lesion?
I think then there is no issue on expanding your new stent, and I don't know of data on this, but I tend to direct stent and avoid less manipulation on that, and probably preventing distal embolization of lipid-rich content. So expansion is not an issue with lipid-rich, but there is reports of distal embolization of lipid-rich plaque. So probably I would choose direct stenting in that situation.
And that makes sense. So let me ask you, as far as mechanical failure goes, we talked about under expansion, measuring, and you have your reference there for free. When you do determine that you have an under expanded stent, what's the treatment approach or algorithm there?
Yeah, so before committing with a new stent, I think you need to ask yourself the question is, first, do you have enough tissue that justify another layer of stent? Or the only thing you need is to expand the old stent further, right? The problem with just ballooning an old stent is that you are not delivering drug on that environment. But a conceptual idea could be you expand the old stent and you deliver the drug through a DCB that recently approved, right? So you don't leave another layer of a metal there. So, but number one thing that you need to address is make sure that the old stent is properly expanded, right? So how do you do that further expansion is either a high pressure NC balloon. We have also on the market some ultra high pressure balloons like the OPN balloon that can interact with calciums that are behind the stent, right? And then you're gonna need to define the need for delivering drug if there is also a combination of excessive tissue on top of it.
That makes sense. So talk to me about, when we're in this scenario where we've determined the stent is underexpanded, we're looking at our reference segments to, determine what the stent size should be. We talked in previous videos about stent sizing in de novo lesions. How do you look at selecting a size for your NC balloon in the instance where we're looking to expand an underexpanded stent?
Yeah, so thank you for bringing this practical point. I think keep in mind that what makes a procedure safe is to avoid oversizing balloons too much, right? So we should be very liberal. I tell the fellows, be greedy on the pressure, but be more conservative on the diameter, right? So a good short length NC, because you concentrate your energy there better and you don't lose energy longitudinally. So short NC balloon, I tend to go nominal size 1:1 to your reference lumen at really high pressure. I mean, a common topic is what is a high pressure, and high pressure is not necessarily 18 or 20, right? You can reach with regular NC balloons 30 ATMs in a pretty safe way because you are in a constrained environment. So these balloons, they rarely rupture, although they are way past the rated burst pressure chart. because that chart was created against air, and that's why they rupture. But when you are putting 30 ATMs in a constrained environment that this balloon is not reaching their nominal size, they don't rupture, and they can be very, very efficient. If you need even more pressure, then you would go with specialty balloons like we have on the markets now through OPN.
Since you mentioned specialty balloons, what type of specialty balloons are available on the market that are helpful in instances of in-stent restenosis?
Yeah, I mean, other than the one that I just mentioned of the ultra high pressure balloon, there is also a category of scoring balloons. One in particular that is very interesting is ScoreFlex, because the combination of an NC balloon with a scoring balloon that can be very effective. But I would reserve this one not for a situation of under expanded stent, but a stent that has quite a substantial amount of tissue also combined, in which you want scoring the fibrotic component, and that might help distribute that fibrotic component better, and your new layer of stent get closer to the old one.
That makes sense.
Now, another category of specialty balloon would be some drug-coating balloons that are coming for us to look at. Now, in everyday ISR, I think it's very difficult to consider displacing a second layer of stent by a DCB. I don't see really a point for that.
Right.
One last device that we didn't mention that can be very efficient in a situation in which you already have particularly in a situation that you have more than one layer of stent and you have a really large amount of NIH, is laser. So particularly if you adopt large fibers, you can debulk a lot of this tissue prior putting a third layer of stent, for example.
So it really, from everything that I'm hearing from you, sounds like, you know, OCT is an extremely invaluable tool when it comes to determining how you're going to treat a patient who has in-stent restenosis. You know, going back to some of the earlier videos, we talked about strengths of IVUS and OCT. Are there any disadvantages to using OCT and ISR, or where does that fall, you know, in comparison to IVUS?
Yeah, I can't think of a disadvantage. I would say there are advantages, like on the novo lesion, particularly on better tissue characterization. As we mentioned, like your decision-making algorithm on calcium is heavily based on the thickness of that calcium, which you cannot obtain with IVUS. And your ability to detect lipid is more. If you think about ISR, sometimes there is a little bit of a nuance of presentation between, is this stent failing because of tissue, or there is part of thrombose associated, and this is also very well characterized by OCT. Since we are on this topic, I would like to mention that if you are dealing with a situation of stent failure and a non-ischemic presentation, for example, you really need to differentiate stent thrombosis versus conventional ISR, right? Because probably if that patient is having a lumen loss due to thrombus burden, the last thing that he needs is another layer of metal, right? So you really need to detect that this is driven by thrombus either plain balloon or thrombectomy, but not another layer of stent. So very, very important also. And just to reinforce, it should be imperative to image.
Mm-hmm. A question I get regularly in the field when we OCT in an ISR situation is, what's the strategy based on the number of layers of stent that we're seeing? Is there a magic number out there that dictates a particular treatment algorithm?
Yeah, so it's fascinating that often you have a patient on the table that you don't have the full medical record on him or her, and it's the OCT telling you how many layers there is, because you just didn't know before. I joke that OCT is your best EMR because it's going to tell you the whole history there. Was the stent properly expanded, how many layers you have, etc., etc. Specific answer to your question, I don't think there is a magic number of layers you can put as long as the stents are properly expanded. So you can go from one example that there is a single stent that is grossly underexpanded because the operator took the time to prep the lesion, and this is a tough position to be now, right? So you need to exhaust your armamentarium to achieve expansion prior to commit with a second layer. And if you can't, this patient is not getting a second layer, because a second layer of underexpanded stent, it's even worse, right? Now, the opposite side, now the patient already have 2 layers or even 3 layers of stent are going to make it extreme. But you compare that stent diameter with your reference lumen and they are properly expanded, there is biologically nothing that prohibits you to put a 4th layer of stent. It's intuitively undesirable, but the key point here is, if you have properly expanded stents, you can go with another layer. If you don't have properly expanded stent, you cannot put another layer of stent.